I want to publicly thank Father Kaczynski. I know it was a distance for him to come last night. He didn't get in until 1 a.m. So let's all say thank you.
Thank you very much.
For the wonderful homily, which gets us started well. And be sure to pick up materials off of the table. There's plenty of things there. Dr. Byrne has a brochure put out by the Life Guardian Foundation that I really, really recommend. It has a sample power of attorney in it, and also cards that you can fill out and carry in your wallet that say you don't want to be an organ donor, you don't want an apnea test, that you don't want to be pushed over the cliff, as I was putting it last night. So that it's a great document to get. You can get it off Dr. Byrne's website, and it's a great document to get to pass on to your kids. And I would like to make one comment about something that wasn't in my talk last night, and it isn't on the weekend schedule, but I happened to watch a video this week of a young man who had a serious sledboarding accident, I think, at 18. Seriously brain injured. He wasn't wearing a helmet. And because he was an adult, his parents could not get any medical information about him. And they were going to assign a unrelated guardian. The mother had to go to court so that she could see the medical information about her own child, who was still dependent at home, but was a legal adult. So if you have legal adults in your family who are still living at home, 18 or older, or if you have young adults in your family who are in those in-between stages when they're not married, they don't have a spouse who's legally responsible, who can the hospitals will listen to, then they are sort of at the mercy of the system. So it's really important to think about those things and get those young people covered by a durable power of attorney that gives someone who's trustworthy the power to make medical decisions for them. And with that, I think we have Jack. I publicly groveled. Please add his website to your list. It's www.defendlife.org. And I want to publicly thank Jack, as I said, because they have financially underwritten the meeting that we're having. So with that, I'd like to introduce Doug Wickham. Doug and his wife Elizabeth are the founders of Lifetree, and Elizabeth was too ill to come and join us. So Doug has come to represent both of them, and I thank him for that. He's a lawyer. He works in bankruptcy law and also teaches at North Carolina Central.
That's correct.
So I know you'll appreciate all the things that he has to share with us, and with that, I'll turn things over to Doug to talk about the transformation of palliative care.
Today, in the next hour, we will describe how our society has been duped by those who wish to control the time and the place of dying. Their successes were gradual, as planned. Before people would accept a death model of healthcare, a profound change in our moral sentiments was necessary. These transformers took charge of the language, and they began and carried out an education campaign to change our view on death. Passage of the Affordable Care Act has greatly strengthened their cause. The harsh reality today is that unless we're healthy and suddenly die in our sleep, all of us will be impacted because the social surgeons have fundamentally transformed our healthcare system. Do you remember that those who pressed for healthcare reform warned that healthcare spending was a primary threat to the American economy? Soon after passage of the Affordable Care Act, Dr. Diane Meyer, who is the director of the Center to Advance Palliative Care, spared no words in criticizing the traditional fee-for-service model, calling it a threat to the American economy. She said, "It's not fair to expect the U.S. government to be able to change our addiction to fee-for-service overnight. Those of us in medicine know you don't take an addict cold turkey. You have to taper, or the patient will die. It has to be a gradual process of change, and that gradual process is what's built into the healthcare reform bill. Very gradual increases in paying people for quality, helping people to get used to working under a fixed budget, which we used to call capitation. You all remember managed care, the disaster that was. But now we call it accountable care organizations, or patient-centered medical homes, or bundling strategies. That was very effectively bashed both during and after the run-up to healthcare reform as rationing and euthanasia. But the fact remains, and again, this is Diane Meyer, unless we are able to think about both quality and cost, we will become a third world nation ourselves just because of healthcare's ruling. Really? Two questions come to mind. Who is now defining quality and value? Why do we need to ration healthcare expenditure anyway? Why not focus on growing the economy and let healthcare expenditures grow accordingly? Fundamental to what she says is a value equation that has become so much a part of the implementation of the Affordable Care Act. We must very carefully listen to what they say because we are dealing with Gnosticism, where black is white, life is death. We must be like our forefathers who deduced that and watch carefully, they deduced that the earth was round by watching ships disappear from the harbor. Over the last half century, through legislation and policy changes, we have directed healthcare spending away from medical research and high-tech medical care to programs that emphasize supportive and comfort care only, by non-medicals. Slowly, by incremental change, we have watched as life care becomes death care. Ione Whitlock of BellberryReview.com has summarized the chronology of this gradual change over the last 4 decades. The names of individuals, organizations, and coalitions, together with their funding, are available at lifetree.org/funding. This Earth is round issue in healthcare can only be understood by observing who is limiting access to traditional care, who is encouraging us to withhold and withdraw, who is setting futility guidelines, who is advocating generous use of opioids. These are the people who want mandated universal health care rationing. Be careful about using the phrase natural death. Years ago, the right to die people elected to define it to include withholding and withdrawing food and water from patients who may not be actively dying and who are in palliative sedation. They have co-opted the language. Decisions that were once controversial, decisions to withhold and withdraw ordinary medical care, medical treatment, are now commonly accepted.
The down arrow, I think, worked this way.
This new eugenics movement began several decades ago with the coming together of several groups. The original euthanasia eugenics people, bioethics centers, healthcare providers, grassroots community organizations, and private foundations. The low-profile movement represented by these groups has created a market for its services. To do so, it had to change minds and hearts. First, of the suppliers of health care, the caregivers, physicians. Second, of the consumers, the patients and their families. The objective has been about building a new system of care that controls the timing and place of death. All this while we fail to observe and analyze why the ship leaving the harbor actually disappears over the horizon. The incremental system changes were given a big boost by the Affordable Care Act. Now the social engineers are very close to achieving their ultimate goal, which is to make their version of end-of-life care mandatory here in America while exporting death care into a one-world order. The modern euthanasia movement in America emerged in the 1930s. It was known as the Euthanasia Society of America. Euthanasia proponents sold themselves as pain relief for the dying. Their original strategy was to attempt to secure legalization of passive forms of euthanasia, the withholding and withdrawing of medical treatment, as a way to change public opinion so that it would eventually accept active euthanasia, commonly known as physician-assisted suicide. But there were conflicts within the movement, and by 1980 there came to be two distinct wings when the more militant elements broke off. We're all very familiar with the militants, their various organizations. Over the years, the Hemlock Society, Compassion and Choices, Death with Dignity, and their successes in a few states, now including California. The moderates wear the mantle of acceptability, but beware. They have successfully distinguished themselves by claiming to be on a high moral ground above those who offer physician-assisted suicide. This more nuanced wing of the euthanasia movement called itself the Society for the Right to Die and Concern for Dying in the 70s and 80s. Choice in Dying in the 1990s, Partnership for Caring in the late 90s, and finally Last Act's Partnership in the early 2000s. Then they seem to disappear. The evidence shows that these same folks have quietly filtered into the new field of palliative medicine. For 15 years, we at LifeTree have researched this third path movement. In her 2005 book about Terri Schiavo, called Terry's Story, The Court-Ordered Death of an American Woman, the author, Diane Lynn, described it as a third path to death. Not wholly natural, not suicide, but something in between. It's the healthcare analogy to the Fabian Third Way political movement in Europe. These moderates insist that there is a big difference between withholding and withdrawing medical treatment and giving someone access to a lethal dose of barbiturates. The more militant, on the other hand, see little or no difference between the two. Professor Dalbingen relates in his book, A Merciful End, it's a history of the euthanasia movement in modern America, how pro-assisted suicide advocates point out the hypocrisy of those who would outlaw physician-assisted suicide while permitting the practice of physicians drugging dying patients into comas and then removing ventilation and nutrition so that the patients die of starvation and dehydration. What were the benchmarks of this transformation? In 1987, Dr. Josephina Magno of Washington, D.C., and Dr. Gerald Coleman, who was director of St. Anthony's Hospice in Amarillo, Texas, called a meeting of hospice physicians in Granby, Colorado. They formed what later became known as the American Academy for Hospice and Palliative Medicine, AAHPM, which is the professional organization for palliative physicians. This professional group joined forces with Choice in Dying to form the Right to Die group called Partnership for Caring. Dr. Ira Byock of AAHPM and Karen Kaplan of Choice in Dying described the purpose of the merger in a Partnership for Caring newsletter at the time. Partnership for Caring will engage in high visibility, high impact activities on both national and grassroots community levels to meet two basic goals. The first is to raise awareness in patients, families, and their providers about the kind of care that every person in the nation deserves at life's end. And the second is to create a chorus of informed demand among consumers for improved end-of-life care that cannot be ignored. Rough translation. Partnership for Caring will conduct a major public relations campaign to gain public support in a political mandate for the Right to Die agenda. Let's take a brief look at early strategies, people, projects, and funders of this third path. Many foundations funded this low-profile euthanasia movement, but two stand out because of their overall impact. The Robert Wood Johnson Foundation funded research and infrastructure, and George Soros' Project on Death in America funded a cadre of professionals. In the last 20 years, these two foundations have provided billions, that's with a B, of dollars to advance their version of palliative care into our American healthcare system and now worldwide. From its beginning, the RWJ Foundation acted like a quasi-university, allowing intellectuals to test ideas with foundation money. The Robert Wood Johnson Foundation is notorious for funding pilot projects so that it can later convince government to replicate them on a much grander scale. For a recent example, in 2002, the foundation began funding a community coalition of healthcare pseudo-professionals with access to healthcare records in Camden, New Jersey, called the Camden Coalition of Healthcare Providers, which is a revolutionary model to ration care for the high-utilizing patients, and this program is now being tested in 10 more communities. Starting in 1989, Robert Wood Johnson launched a 6-year support study of how 10,000 patients were cared for at the end of their lives. Dr. Joanne Lynn, currently director of the Altauern Institute Center for Elder Care and Advanced Illness, led the study. It found that fewer than 20% of us had signed living wills or other advanced directives. They knew that advanced care planning, advanced care directives, was a high-mark prerequisite of legalizing the control of death. Getting people to codify their goals of care has been a major strategy in the last 20 years. Enter George Soros in the mid-1990s, and the momentum changed. His 1994 speech at Columbia Presbyterian Medical Center announcing the formation of Project on Death in America included this summary statement. The mission of the project is to promote a better understanding of the experiences of dying and bereavement, and by doing so, help transform the culture surrounding death. In November of 1995, Soros called 20 foundations together who were committed to transforming the culture of dying. In addition to officials from Soros' Project on Death in America, part of his Open Society Institute, and RWJ officials, the list of attendees included people from many other foundations: AARP, Commonwealth Fund, Greenwall Foundation, Mayday Fund, Cornfield Foundation, Milbank Memorial Fund, Nathan Cummings Foundation, the Rockefeller Family Office, Gerbeau Foundation. Also in 1995, RWJ began a big communication and outreach effort called Last Acts. Last Acts worked at the grassroots level. They held their first leadership conference in March 1996. 140 national leaders came to Washington, D.C., and they produced challenges, objectives, and opportunities, tactics. Daniel Callahan described the Last Act's three-pronged strategy moving forward. Change the education of healthcare professionals. Change healthcare institutions, public policies, and regulatory apparatus. And engage the public to gain support. Two prominent Catholic lay people were present at this meeting. They have since become the experts who articulate the American Church's views about end-of-life decision-making. Joyce and Dying's Karen Kaplan had this to say about advanced directives. Advanced directives are tools like staples, shovels, or irons. They're very good tools, but unless you pick them up and use them correctly, they won't work for you. They needed some bridges with two-way traffic between those working on the big picture at the institutional level and those advocates and activists working in the communities. Soros' Project on Death in America provided the physician leaders to integrate the Robert Wood Johnson projects into mainstream medicine. The first Soros scholar-led projects were directed at professionals. Something called EPIC, E-P-E-C, was for physicians, LNEC for nurses. Other projects were aimed at changing the general culture, including RC EPIC for Roman Catholics and APPEAL for African Americans. Their institutional engine of change was a new view of palliative medicine. So said Newsweek in its cover story on October 9, 2006, titled, "Fixing America's Hospital Crisis." This is what it had to say. Determined people are transforming the way U.S. hospitals care for the most seriously ill patients. The engine of change is palliative medicine. What is this engine of change? We have identified some of the organized, determined people. Let's take a closer look at their version of palliative medicine. Today's palliative care is much more than simple symptom management. It is a process. In the beginning, palliative care applied to near-death cancer patients. The contrast between the old and the new is pictured in a 2001 article in the Journal of the Royal Society of Medicine. The traditional view of palliative care was associated with volunteer hospice care for cancer patients. The current view of palliative care is not only for those cancer patients, but for those of us with multiple chronic conditions, including dementia, and anyone with a serious illness. The diagram shows that the new view is they're trying to introduce palliative care at the time of diagnosis, and then increase the proportion of symptom management palliative treatments over traditional curative treatments to the point of death. Note that palliative care now includes a period of managed grief and a before-death period of anticipatory grief. The third path is totally committed to upstreaming or changing the American healthcare system so that palliative care is integrated into traditional care very early on. The official definition of palliative care is still a work in progress. You look at their stuff and it keeps morphing. But this much is certain. Palliative care is critical to the success of healthcare reform. So if we're unhappy with the Affordable Care Act, it behooves us to understand palliative care. Several parts of the Affordable Care Act were written by palliative care professionals. One of the original Soros scholars, Dr. Diane Meyer, began the Center to Advance Palliative Care, CAPC, with Soros funding shortly after her change of heart speech disclaiming physician-assisted suicide was reported by the New York Times. At first, CAPC focused on bringing palliative inpatient units into the healthcare system, hospitals. Now, CAPC and their followers are training people to sustain palliative care programs across all healthcare settings. Hospitals, rehab centers, nursing homes, assisted living centers, outpatient clinics, community healthcare organizations, and to encompass all clinicians with their training, including the generalists. The CAPC Soros RWJ version of palliative care is about coordination of care by an interdisciplinary team. The main members of the interdisciplinary team are physicians, nurses, social workers, and chaplains. They are working hard to educate caregivers to become part of the team. More about that later. The palliative care team helps to develop relationships. They are taught to be supportive rather than to offer curative medical services. They are taught to base their comments on the quality of life argument. They try to bring consensus that it is time to let go. Diane Meyer describes the work of the palliative care team this way. A major, if not the largest part of the team's work is to help patients clarify values and treatment preferences in the face of advancing illness and prognosis and in light of realistic options for care. The process of goal clarification requires intense, time-consuming face-to-face conversations with patients or family members. The rapid rollout of palliative medicine as a board-certified specialty has been nothing short of phenomenal. From 2001, when 4 major palliative care organizations and the Right to Die Partnership for Caring began to develop national consensus project guidelines for quality palliative care. To the first board certifying examination in hospice and palliative medicine in 2008, to a requirement that all palliative professionals have 1 year of fellowship training in 2012, palliative care, palliative services have become part of regular medical services. These social engineers created the official guidelines for this new subspecialty. They got it recognized officially by the AMA. And they now require that you complete one of their fellowships before you can even sit for the board examination, all within 12 years. Not only do they intend to pass legislation to subsidize specialists in palliative medicine, they intend to regulate the continuing education of generalists so that all become familiar with the palliative philosophy of care. We hear a lot about quality and value-based care. They define value of a treatment by a value equation. Value is quality over cost. They're building the business case for palliative care. So the bureaucrats at the National Quality Forum propose to tie payment to value. They propose to scientifically identify the value of care given by the many providers who care for individuals with multiple chronic conditions based on some sort of value equation. Can this really be done? How will they be able to link cost with quality measures? How will the bureaucrats go about defining the science of a performance measurement for quality? Can you imagine the number crunching that will be needed? Never fear. Robert Wood Johnson Foundation is hard at work funding much of their research. Second, and more basic, they must try to define quality. They look to the National Quality Forum, which is a national membership organization created by Robert Wood Johnson Foundation to develop and implement national quality measures of improvement. NQF has adopted the Institute of Medicine's 6 quality goals: patient-centered, beneficial, safe, timely, equitable, efficient. Notice that we are not talking about health care that is focused on protecting and preserving life. Rather, that which is deemed important as reflected in the 4 principles of bioethics: autonomy, non-malfeasance, benevolence, and justice. And then we take those and we put them together with categories of health and CAPC triggers for palliative care, and we have more tools for the planners. The importance of electronic health records to the Third Path movement cannot be overestimated. They plan to use EHRs to segment the population as a tool for guiding clinicians in future decisions about clinical care. Here is a model from one of the leading Third Path gurus. Dr. Joanne Lynn outlined 8 categories of health to separate out the curable from the not curable. And the spectrum runs from healthy all the way through long dwindling course, frailty and dementia. In 2007, Dr. Joanne Lynn was the lead author of a Center for Medicare and Medicaid Services article proposing a Bridges to Health model. That model ties the 6 NQF bioethics quality goals to her 8 patient categories and proposes that planners shift to a matrix model of resource allocation over the 48 cells in the matrix, away from the traditional model of tailoring services to each patient's situation, which is said to be too difficult and costly. Make way for the army of planners. In one of her bellberryreview.com postings, Ione Whitlock has more fully described that most of Dr. Joanne Lynn's work has been about constructing more efficient bridges to death. Under the direction of Diane Meyer, CAPC has become a well-oiled training and marketing machine. Among its projects was to develop a list of triggers for recommending palliative care consultation in the presence of a serious or chronic illness. Several of these triggers indicate clearly how the new palliative care does not wait to enter to the end of life as it used to. Fully integrated palliative care targets those with multi-chronic conditions, the expensive ones. Note especially declining ability to complete activities of daily living, patient, family, or physician uncertainty regarding goals of care. Here they come. Patient or family requests for futile care. Use of tube feeding in cognitively impaired or seriously ill patients. Limited social support plus a serious illness, homeless, chronic mental illness. Patient or family psychological or spiritual distress. These triggers introduce the palliative care process into patient populations which may be declining but are not yet dying. Note especially that those with limited social support and/or declining abilities are identified as ripe for palliative care. They talk about patient-centered decision-making, but their argument is more like the tragedy of the commons. Whose autonomy is it, anyway? The traditional understanding of medical decision-making was based on a patient-family consultation with a specialist or general physician who was trained to do no harm. Today, we hear more about informed consent and that it leads to patient-centered decision-making. We hear that palliative care is about matching care provided to what the patient wants. However, if you read carefully what they say, the interdisciplinary team is trained to find consensus based on communitarian ethics, which is a mini version of bioethics. Decisions are based on what is the greatest good for the community rather than the good of the patient. According to the principles of communitarianism, if there are social consequences of it that the community suffers from allowing people to obtain service that they want, then someone has to say no. Listen to what the then president and CEO of the National Quality Forum, this folks who develop standards and guidelines, Dr. Christine Cassell, had to say in 2007 about managing medical resource for the population's health rather than the individual's health. She said, physicians must be committed to managing medical resources. This responsibility is controversial, largely because it can be seen as in conflict with the more traditional altruistic commitment of the physician to the patient. She continues, the fee-for-service model does not allow physicians to affect where saved resources go, so why would they try to avoid costly interventions in the name of helping other patients? It's the old tragedy of the commons argument. In the same journal, the command to good doctors and hospitals by Rationer-in-Chief Dr. Ezekiel Emanuel is more emphatic. He gives physicians the ultimatum. Physician autonomy and leadership can only be affirmed if accompanied by acceptance of responsibility and accountability. Unless physicians want to be marginalized, unless they are willing to become just another deckhand, they must accept and affirm that they are responsible for controlling healthcare costs. Stuart Altman, professor of national health policy at Brandeis University, was asked at a public meeting of providers and consumer advocates in Winston-Salem, question from the floor, why are we getting penalized when we take care of the patient? Altman's answer, I tell them, you are big, rich, and powerful, you have the ability to resolve the problem, but you will be part of the solution whether you like it or not. A friend recently reminded me of the late Judge Robert Bork's comment in his book Slouching to Gomorrah, where he wrote, it is ironic that our supposed freedom to choose death has made it far easier for others to choose our death, as the autonomy is often theirs, not ours. From last acts to what is now called the Coalition to Transform Advanced Care, CTAC. We call your attention to the new Coalition to Transform Advanced Care, which operated under the radar for a couple of years. It was begun in 2010, just after the passage of the Affordable Care Act. CTAC is now very much a part of the lobbying scene in Washington, D.C. We'll discuss their legislative agenda in more detail this afternoon. What happened is that the last acts people active in the mid-1990s have come back together to form a much larger coalition. CTAC now has over 120 members. patient and consumer advocacy groups, healthcare professionals and providers, private sector stakeholders, faith-based organizations, academia, the payer community, and others. Their goal is to carry out the Last Act's agenda, manage the news media, promote new legislation to accompany the Affordable Care Act, and help community groups become part of the culture of death. CTAC is co-chaired by former AARP President Bill Novelli and the former chairman of the Right to Die Group Partnership for Caring, Tom Koutsoupis. They know that advanced care planning, if done the way they want it, would be their main tool. As their name implies, they are the coalition to transform advanced care. They want advanced illness planning to result in goals of care easily found in the electronic healthcare record. Examples of the forms that they would like you to execute are the living will, the post form primarily. The POLST, P-O-L-S-T, form is their most important tool. Community facilitators are being trained in how to coax patients into making limiting choices for curative treatment on the POLST form. CTAC wants the government to fund these discussions and to pay these facilitators, who are often social workers. Sarah Palin called these government-paid end-of-life discussions death panels. Because of the uproar, government funding for these sessions was dropped from the Affordable Care Act in order to facilitate passage, but they have been patiently working to bring them back. Currently, the government is about to implement 2 new CPT reimbursement codes with which to document these discussions with a doctor or other qualified professional. Keep your eye on CTAC. If you wonder about their long-term aspirations, think global. It is not by accident that Brad Stewart, who is a board member of CTAC, just returned from Rimini, Italy, where he presented a couple of months ago, where he presented at the Communion and Liberation meeting in August, a revealing talk entitled "Healing When There Is No Cure at the Beginning and the End of Life." Note the use of the word healing, not curing. Healing does not mean bodily healing or preserving and protecting a person's life. Healing in the palliative care lingo means a healing of the spirit, more as defined in New Age. Robert Wood Johnson Foundation has infused over $200 million to develop a network across the country of interfaith volunteer caregivers. Faith in Action, begun in 1983, is now called Interfaith Volunteer Caregivers Program. The program trains community volunteers who offer free respite care to families. They are trained in how to advise on treatment choices, become a patient advocate, encourage organ donation. They especially work within faith-based communities, so look in your church bulletin. Here's what you might find. We drew this from the bulletin in the parish where we occasionally go to church in Raleigh. Joanne Lynn calls for a caregiver corps similar to the Peace Corps. One campaign to bolster volunteer activities and infiltrate faith congregations is directed by Caring Connections at the National Hospice and Palliative Care Organization. Their booklet called "It's About How You Live" in Faith Community Outreach Guide is a manual on how to partner with congregations and is designed for use by hospices and the Community State Partnership End-of-Life Coalitions. Another booklet available on that site to help organize communities is called the Naturally Occurring Communities Toolkit. John Kretzmann, on the board of Gamaliel Foundation, which is a Linskyite group, describes how to organize caregivers in faith communities. National standards for the caregiving industry are popping up all over the place. The U.S. Department of Labor recently mandated that direct care workers must be paid the minimum wage. California is considering a law that would require all home care aides to be certified and licensed to meet government guidelines. I guess if you take care of Granny, you got to get a license in California if they pass that one. Will all this political activity in the caregiving industry benefit the patient? Or will the increase in cost of regulated caregiving make families be more willing to concede to the pressures of palliative care? You may wonder what happened behind the scenes in the year before the passage of the Affordable Care Act. Families USA, developed by the Peddlers Foundation in Massachusetts and its Boston counterpart, Community Catalyst, helped the Obama administration get across the finish line. In Community Catalyst, Kate Peddlers had developed strong consumer organizations in every state, which were linked into a collective and powerful voice. After the special election in Massachusetts, which elected Scott Walker, and when the great momentum toward passage of the Affordable Care Act seemed to be slowed, this important consumer health group sponsored an off-record call to a huge number of community activists all over the country. One can listen to Ron Pollock. I've got a link to it in the footnotes here, but you listen to Ron Pollock, the executive director of Families USA, explaining their strategy to bring health reform across the finish line after what he called a week that sucked. Alinsky had favorable relationships with the Catholic Church in Chicago. It is no surprise that faith-based communities were also a major source of the momentum in those last days. In April 2009, over 40 national religious organizations signed up to discover how they could support comprehensive health care reform. They formed We Believe Together, Healthcare for All. Remember those folks chiming in. Some of you are well aware that the Catholic Campaign for Human Development at the USCCB funds groups that adhere to principles which are inconsistent with Catholic Church doctrine. Sadly, it is true that CCHD is involved in the culture of death at end of life as well. The number one recipient of all CCHD grants is the Industrial Areas Foundation, which was founded by Alinsky himself. IAF is his lasting contribution to those who wish to radicalize. IAF recruits local churches and teaches how to challenge the power structure. Catholic writer Paul Lakotis wrote that CCHD was created to be a permanent funding source for IAF. IAF has spawned several faith-based community groups operating under the umbrella of organizations such as PICO, Gamaliel, and DART. Take one example. CCHD money goes directly to the PICO National Network. A partial list of PICO activities makes it clear that CCHD has joined the list of private philanthropies who fund death care. PICO is a key partner at the CTAC Interfaith and Diversity Workshop. PICO has ties to Appeal, a Right to Die program to change the culture of care for African Americans at the end of life. PICO lobbied heavily for healthcare reform. With Robert Wood Johnson funding, PICO is now helping to redefine the healthcare delivery system in Camden, New Jersey, to be used as a national motto of community accountable care organizations. In an interview with the Center for Practical Bioethics, Dr. Joanne Lynn has called for more community involvement. According to Lynn, we have overinvested in medical care. We have had the wrong set of priorities. What we need is more community volunteers to give companionship, food, keep people safe. Lynn argues that hospice manages those who die within a short period of time, but our system lacks a well-funded program to address those with multiple chronic conditions. She is also saying that better quality health care means a community health workforce and fewer hospitals. Calling it improved quality care, the Third Path movement is permanently restructuring the entire healthcare delivery and payment system. Using more community services, the traditional separation between primary providers and public health professionals is eroding. The public health model will soon dominate the health scene as community-based palliative care takes over. Section 3026 of the Affordable Care Act allocates $500 million over 5 years to test models in the care transition program. The stated goal is to prevent hospital readmissions, to prevent patients from bouncing back. Care managers with transition coaching, training, and experience will be paid to monitor symptoms and work on advanced care planning. It's no coincidence that Dr. Joanne Lynn and Eric Coleman had the foresight, even before the passage of the Affordable Care Act, to develop a year-long Organizing the Health project in Colorado. While the act was getting close to passage, they were in Colorado. What were they doing? They were having their Organizing the Health project in Colorado to build power among communities for collective action, to help build the community-based organizations who could then apply for these new CCTP grants. It's interesting also to note that in Colorado, they brought in expert faith-based community organizer Marshall Gantz and 2 of his proteges with connections to George Soros as they developed their models. These CCTP partnerships seek to standardize the way people move across care settings using a trained community support navigator who coaches the patient and family to make sure the patient is decided on goals of care, mainly a completed post form, and who look for red flags when the patient's condition worsens so they can notify the palliative care team. It is disturbing, yet not surprising, to find out that Catholic Charities in the Archdiocese of Chicago was approved to be the CBO for one of these grants. Will Catholic Charities become part of our nation's network of community healthcare practitioners? Could be. The CCTPs are paid a pot of money. It's a flat rate per beneficiary served in the target population, but the CCTP is then able to allocate funds within the population, determining who will get more services and go to the hospital and who will get less and be referred to palliative care. These CCTPs will have access to your electronic healthcare records to guide their decisions. As Dr. Joanne Lynn said, these are organizations with clout. I know you all heard this one before. If you read Marianne's post recently, you will have seen it, but listen to how Daniel Callahan, a major Third Path proponent, described the problem back in 1983. Denial of nutrition may, in the long run, become the only effective way to make certain that a large number of biologically tenacious patients actually die. Let that sink in. And he observed that, at the time, A deep-seated revulsion exists over the prospect of withholding or withdrawing nutrition and hydration. We're naturally repulsed by that. What have they been doing over the last 30 years? And how repulsed are people now? We have described in late 1984, a story appeared in the New York Times. It's important because it reported how both wings of the Right to Die movement and emerging bioethics think tanks, such as the Hastings Center, led by Daniel Callahan, were working together to change attitudes and behavior, working to change the culture, painting the issues in terms of compassion versus technology. We've tried to describe how all of this has played out to you today in some detail. And we ask you to carefully examine the new field of palliative medicine that has a planned set of triggers to initiate a palliative care consultation, which downplays the curative power of technology, which gives us more federal bureaucracy with access to our electronic health records so as to categorize the population, employs lavish use of morphine, and times our death based upon a team coach decision. Palliate means to reduce the violence of a disease. Palliative care used in the right hands can make the truly dying patient's experience more tolerable. All that for sure. Palliative care should enhance the remainder of each individual's life, not rush them to death. If you are being offered palliative care today, the chances are that it is the CAPC version. The number of professionals practicing traditional palliative care is in decline. Soros and Robert Wood Johnson funded people have established the guidelines and regulations for palliative care as it is officially practiced and paid for by Medicare now. Each day, physicians, nurses, chaplains, and social workers are being exposed to their propaganda and then required to practice it. Today's palliative medicine has become the vehicle of those who wish to transform good traditional health care into death care. Take heed of Isaiah's warning. Woe to those who call evil good and good evil, who put darkness for light and light for darkness, who put bitter for sweet and sweet for bitter. We pray that our message falls on fertile ground. We are all called to become better informed. People who want to understand will be like watchmen in the night, guarding and defending their loved ones from stealth attacks in the later chapters of life.